So moving on to the next heading, which is liver health and management. Apart from abstaining from anything that increases the toxic load to the liver, in brackets alcohol or chemicals, what other recommendations would you make to optimize liver health, considering we can't treat the underlying cause easily? Or is there any benefit from abstaining from these things? So yeah, what I advise the patients who come to our clinic is essentially to view the Fontan circulation as a risk factor for progressive liver disease. So, and like anything, you don't want to amass too many risk factors. Generally, alcohol, I would recommend abstaining if possible, and really, you know, if you can't abstain, then you know, minimizing to you know, the lowest amount possible, and you know, is really important. The most common form of liver disease that we're now seeing globally is fatty liver disease. So it's obesity-associated fatty liver disease. So making sure that you're exercising, keeping fit, you know, keeping a balanced diet, those things are really important. The other things that we screen for and look for are viral hepatitis. So if you're born in Australia and or have been in the last 20 years, you should be vaccinated against hepatitis B. But if you've come from overseas, that may not be the case. So hepatitis B vaccination is something I advise, although it's very, it's less common to get that in Australia, but vaccination is freely available. And similarly, avoiding risk factors for hepatitis C, which is a blood-borne virus. So you know, avoiding things like intravenous drugs or unreputable tattoo parlors that don't sterilize adequately. So they're the main lifestyle things to change. So again, staying fit and minimizing that chance of developing obesity-related fatty liver disease, reducing alcohol, and keeping a balanced diet. The next question is, what can be done to support liver function in the person with the Fontan? I think I've covered that there. Will having regular electrolytes help at all, or do you suggest any supplements that may assist the liver? The short answer is no. There's been lots of things that have been tried and tested, and there's lots of things that you might be sold if you go down the health, the liver aisle in the health food store. And most of them are misnomers. So you can buy products like liver detox, and it's quite ironic because the function of the liver is to detoxify. So these things are marketing ploys that none of them have any benefit that's been proven in liver disease, particularly Fontan-associated liver disease. So it's certainly a case of less is more, and I'd avoid any regular supplements that are directed at the liver unless, or vitamins and minerals, unless there's a specific deficiency that you've got. So for example, vitamin D deficiency, if you're low in vitamin D, then, you know, it's perfectly reasonable to take vitamin D. But if there's no deficiency, you should be able to get most things in your diet, vitamin D being the exception, where, you know, you need some sunlight and working kidneys. Next question. Are there any national and international bodies that discuss liver management and treatment? And how might the post-Fontan liver impacts and management get shared with liver clinicians across the world? So the answer is yes. There's a big push in the liver community, as well as certainly in the cardiology community and in the transplant communities, to try and standardize and optimize the way we diagnose and manage people with Fontan-associated liver disease. From the liver perspective, there's a big European consortium who are working together under the umbrella of the vascular, or under the European Association of the Study of the Liver, but the consortium's the Vascular Associated Liver Disease Interest Group, and they've released, or they've published a few papers on Fontan-associated liver disease through collaboration in the US. You'd be aware that here in Australia and New Zealand, the Fontan Registry is a world-class registry, and there's been projects already and publications from this group on liver disease. Similarly, in the US, there's also been lots of movement forward in the cardiology space, as well as by hepatologists, and certainly in the setting of transplantation, the US is certainly leading the way as far as international collaboration. On a personal note, I think most of us have quite strong connections with our other colleagues in the field. So hepatology is a very small community, and same with congenital heart disease is a very small community. Transplant is a very small community. And so we have very tight international links, which we call upon for advice, but also for collaboration for research. So I hope that answers that question, but it's certainly a priority in the global liver community in places that have people who've undergone Fontan circulation. Next is what impact do medications such as blood thinners, ACE inhibitors and diuretics have on the liver? Fairly minimal in general. The exception would be ACE inhibitors if you have significantly advanced liver disease, and that's related to some of the circulatory changes in the kidney. You might find that it might worsen kidney dysfunction. Most blood thinners are fine. Some of the newer anticoagulants may have may cause some abnormalities in the liver tests, but they don't cause any long-term fibrosis. But you'll often be changed to a different agent if, and so I'm talking about things like rivaroxaban or apixaban. You might be changed to a different agent if the liver tests aren't completely normal. Non-steroidal anti-inflammatory drugs, so things like ibuprofen aren't great for the liver, but paracetamol in regular doses is fine. The only way you can get paracetamol toxicity, well, there's a couple of ways. There's one, if you take a lot of paracetamol and overload the system, and the second way is to be very malnourished and take regular paracetamol, because you become deficient in the enzyme that processes paracetamol in the liver. But paracetamol in the standard doses of up to 4 grams a day is safe. Things like diuretics don't usually impact the liver, so most diuretics that are used are fine. And I guess there's always potential with any drug to have an adverse reaction in the liver, but it's very what we call idiosyncratic, so you can't predict it. So some people may have a reaction to an antibiotic or to a different drug, and there's not any good way of predicting that really limited risk. But it's something that if you've had a reaction to a specific medication in the liver before, that might predispose you to other groups of drugs or avoiding a certain class. But again, a liver specialist will be able to advise you further with the specifics. And the last question is, can scarring or hardening of the liver be repaired or reversed? So I'll be answering that question with the next heading, which is called liver cirrhosis and Fontan-associated liver disease. So it starts off by saying, what is cirrhosis? So I mentioned this before, saying that we grade fibrosis. So fibrosis is the process of scar tissue forming. And in the liver, fibrosis is reversible up until the point of cirrhosis. So cirrhosis is what we regard as irreversible liver damage or irreversible scarring on the liver. So it's the scar tissue that's really set in. And it's the same thing with other tissues. You might find that if you have a small cut on the skin, you might have a scar that's there for a little while, but then fades away completely. Or if you repeatedly damage that part of the skin, you have a thicker scar that won't go away, but might shrink and change in size. And that's how we view fibrosis in the liver. So it's a chronic wound healing reaction to ongoing damage. And the end stage of that is cirrhosis. So we grade fibrosis in stages. So the common staging system that we use is based again on liver biopsy and largely centers around viral hepatitis, but we have different scoring systems for different types of liver disease. In Fontan-associated liver disease, there's been a proposed specific score as well that's different again from the viral hepatitis scores, but they all use generally the same principles in classifying things on a spectrum, either from 0 to 6 or 1 to 6 or 0 to 4. And I think that's probably what the next question refers to, about 4 levels of liver cirrhosis. So often, to determine or to delineate, we're talking about fibrosis, we put an F in front of that number. And so the scoring systems from F0 through to F4, F4 being cirrhosis, F3 being advanced fibrosis, so not quite cirrhosis, F2 being significant fibrosis, there's a little bit of fibrosis around there, and F1 and F0 being no or minimal fibrosis, respectively. Sorry. I guess the point to make is that although cirrhosis might be present, and I did mention it's the end stage in the sense of scarring, but it doesn't necessarily tell us much about liver function. So you might have cirrhosis on a biopsy, but your liver might still be performing all its functions of making proteins and clearing toxins, and its immune function, et cetera, et cetera. But the implication of cirrhosis is that you may go on to, it puts you at risk of developing further liver-related complications and liver failure. So liver failure is when the liver isn't doing its job, or rarely developing a liver cancer. So cirrhosis is in fact the major risk factor for developing liver cancer. And that's one of the things that we look for once we've established that diagnosis. So the next question is similar to the one I didn't answer from the section before, which is, can liver cirrhosis be reversed or improved for people with normal hearts and circulation? So as mentioned, by definition, we've traditionally not thought of cirrhosis as being reversible, but that's been challenged recently. And in fact, we know in very, very early stage cirrhosis, so instead of being this solid line in the sand that you've got cirrhosis and you don't, it's actually more of a grey zone. And we've seen in patients with viral hepatitis, if you cure their hepatitis C or you control their hepatitis B for a long period of time, people who've just got very, very early cirrhosis may regress down to F3 and other reversible stages of fibrosis. But generally, once you've got the diagnosis of cirrhosis, you've always got it essentially. And similarly, the other things that we would do, so people with obesity-related advanced fibrosis, so that F3 level before we go on to cirrhosis, we might find that with bariatric surgery or stomach reduction surgery, they lose a lot of weight and regress back to an earlier stage of fibrosis. But to go back to the question, so although cirrhosis may not be reversible, those earlier stages of fibrosis certainly are, depending on the cause of liver disease. So again, with autoimmune liver diseases, if we can treat them, that may reduce those earlier stages of fibrosis, so F2, F3, well, you don't really have to go anywhere from F1 really. The next question is, liver cirrhosis is commonly associated with the Fontan circulation. One study finding that the majority of Fontan patients over 25 who had a biopsy were found to be diagnosed with clinically silent cirrhosis. Causation is not clearly defined. Some voices speculate the liver damage might be sustained pre-Fontan, during the operation, or post-Fontan due to the elevated venous pressure. Are you aware of any studies that shed light on the causation, and if so, share with us the findings or trending theories? So that's a big question to unpack. But the first part, so there's been quite a few studies where in some centres they do biopsy the liver regularly. Particularly this was before the non-invasive tests that we have available currently were invented or available. And in those centres, as mentioned, the older you get, or the longer the time is since the Fontan circulation, there is some degree of fibrosis that develops on the liver, and that might be a mild stage of fibrosis, or for some people, a more advanced stage. But certainly, the longer you are out from Fontan, the higher that risk of liver fibrosis is. And that's more reflective that this process takes a long time to occur. So the second part of the question is, what are the causes? And I've avoided answering questions like this just up until now to address it here. And really, the question is asking whether the damage is done before the Fontan operation, during, or afterwards. And so the first thing to say is that the liver fibrosis is, again, a chronic process, so you need long-standing damage. The liver responds very well to acute damage. So if you take a medication, it causes some damage to the liver, like some herbal preparation, for example, the liver will regenerate and go back to normal. But if you keep on, if the causative factor for the liver damage doesn't go away, then that's when you develop fibrosis. And if it still doesn't go away after many years, you can then develop cirrhosis. And that's true for viral hepatitis, as I mentioned, with alcohol, particularly, that's the case, or even fatty liver disease. So that's the first point to make, that to get to fibrosis, advanced fibrosis or cirrhosis, the process has had to have gone on for several years. Some people may have developed some issues with liver damage before the Fontan circulation, and that might be because they've got an underlying condition that might predispose them to liver disease. But secondly, it depends on what the original abnormality was, or what the original anatomy and was in relation to the circulation. So, and that's particularly true of how much oxygen is being pumped around the body. And so the more cyanotic the condition is, so the less oxygen that's in the bloodstream due to the cardiac abnormality, the less oxygen is getting to the liver, and that might induce a fibrosis process. And so the way that was kind of discovered was that some people have different patterns of fibrosis compared to just venous congestion alone, and I'll explain what that means in a minute. So the rest of the question says, is there any liver damage during the operation? Again, during the operation, it's very uncommon for that to cause, or it would be almost impossible for that to cause long-term damage to the liver. So you might develop short-term damage to the liver from low blood pressure, or from anesthetic drugs, or from antibiotics, but usually they should resolve within days to weeks to months. So that's all acute things that the liver should be recovered from, even if there's some mild fibrosis to begin with. So for the vast majority, and what we think the predominant process in Fontan-associated liver disease is the problem with blood getting out of the liver, and that's because the heart isn't pushing blood forward as well in the Fontan circulation, and the liver is just next to the heart. So it's the first organ to have to deal with all that pressure. And basically the liver becomes congested, and we see the fibrosis developing around the branches of the veins that take blood back to the heart. And that's what we call congestive hepatopathy, or just means congestion in the liver causing liver disease. And we see it in other types of cardiac disease that aren't Fontan, so people who don't have a right heart side that's working very well, so have severe valve problems on the right heart side, for example, sometimes get a similar problem, and a similar pattern of fibrosis. And again, it takes several years for that to occur. So that the predominant cause of Fontan-associated liver disease is definitely post-Fontan, and as I mentioned, the degree of fibrosis is usually proportionate, or it's related to the time since the Fontan. The second thing to mention is that although the blood getting out of the liver is a problem, there is also a problem with oxygen getting into the liver, and that's because some people with Fontan circulations have lower oxygen levels in the blood than people without Fontan circulation. And so the liver is lucky enough to have two blood supplies, so it takes most of its blood flow from the gut. So as I mentioned, there's a big vein called the portal vein, which is kind of like the highway into the liver from the intestine. So it takes all the blood you absorb from your guts and takes it into the liver. That provides about 2/3 of the liver's blood flow and about half the oxygenation. So half the oxygen comes from the gut. And the other blood supply is from something called the hepatic artery, which provides about 1/3 of the blood supply, but again, about 50% of the oxygen. And it's like any other artery in the body. So the amount of oxygen is related to how much oxygen you get from your lungs and put in there. And some people with Fontan circulation have a significantly lower amount of oxygen in the blood, and the liver reacts to that. And that's a similar reason why some people or some children might have, it might be several years before they get to Fontan completion, and several years of a low oxygen level, lower than normal oxygen level, and that might be another driver for early onset liver issues, and changes the way the liver actually deals or regenerates and grows essentially. And so one of the reactive things that we see in the liver is the formation of nodules. And nodules in people without Fontan-associated liver disease usually means cirrhosis when we see nodules. It doesn't necessarily mean cirrhosis in Fontan-associated liver disease, but it does mean there's a problem with the blood supply to the liver, either the blood going out or the blood going in. So we see it in other forms of vascular diseases of the liver where you get nodules. And those nodules might be apparent on ultrasound, but the best test to find them is usually an MRI. So I hope that answers that long question. And the next two questions are fairly similar. So what is Fontan-associated liver disease? What is the exact cause of Fontan-associated liver disease? What timeframes are you seeing liver disease begin after Fontan? So I think I've answered those, thankfully. On to page 2. Is there anything we can proactively do to slow the onset of liver disease? Again, I think everyone should be screened for other causes of liver disease if you have abnormal liver tests. And regardless, everyone should be screened for those reversible things. So, vaccinate for hepatitis B if you're not. And look for things like hemochromatosis, which is a commonly transmitted genetic mutation, or alpha-1 antitrypsin deficiency. These are all conditions that we screen for in liver clinics, and hepatologists or gastroenterologists will look for. So they're things that I guess add to the active management that you do in the clinic. But as far as from as a person living with a Fontan, the things I've mentioned before, so abstain from alcohol. Make sure that you don't become obese, minimize your risk factors for viral hepatitis transmission, get vaccinated for hepatitis B. They're the main things. And then, have you found liver damage occurs faster in the various types of Fontan, e.g. fenestrated versus non-fenestrated? I guess it's a bit more complicated than that, and I don't think it's the type of Fontan that makes a difference. It's more the health of the Fontan, so how well it's working, and that's again, the amount of increased pressure it's generating back on the liver for us, and secondly, the amount of oxygen in the blood as a result of the Fontan circulation. So, if the oxygen levels are low and there's a lot of pressure on the liver, then we don't expect the liver to be that happy, and we might see more accelerated Fontan liver disease there, as opposed to someone who's got a very well-functioning Fontan who has no limitations on their lifestyle. The other thing is that obviously people with more risk factors for liver disease and liver disease progression are likely to progress faster, and they'll have more than one pathology, so more than one process going on when we take a liver biopsy, or if we take a liver biopsy.